All right. Well, thanks for having me here today. It's actually sort of humbled to follow Dr. Rahani. So I was a little perspective. I always like to tell a few stories to make it interesting. I was I was resident in radiology at a place called the Postgraduate Institute of Medical Education Research, PGI, Chandigarh. And at that time, there was a paucity of good physics teachers. And somebody had mentioned the name of Madan Rehani to me, who was at one of our sister institutes at All India Institute of Medical Sciences, where he was a physicist. And this is 1994. I never actually ended up having the pleasure of ever meeting him. I saw him for the first time today. So it was kind of a little bit of a deja vu moment. So what I'm going to bring today, reason I'm talking about radiation dose reduction for CT-guided interventional procedures is very closely tied to what I do. So I have a deep interest in CT. I'm the director of CT at UC Davis Medical Center, but I'm also a unicorn. I'm an interventional radiologist as well. So I do CT-guided interventional procedures. And as you might have just heard, I did my initial training was in India, and I got very adept in the use of ultrasound. So ultrasound has always been a favorite modality of mine. So what I was able to do in my practice in the United States, I'm able to marry my knowledge of CT, my skills in interventional radiology, and my skills in ultrasound. And that's the genesis of this talk. So there's a publication from 2011 from the Mayo Clinic that looked at radiation doses for CT-guided procedures. So just simply would like to show over here that the radiation dose, the effective dose, and the skin doses are noted to the right. The effective dose is directly proportional to the complexity of the procedure, starting with ablations, which can have an effective dose on average, mean effective dose of 120, and then it drops down for biopsies to about effective dose of 14. And the corresponding skin doses are noted for these procedures. So this data is a little dated. It's from 2011, and I'll show you what we can achieve now in 2023. A quick slide on radiation risks in CT, deterministic and stochastic. I believe this has been extensively discussed at this meeting. Deterministic risks need a threshold dose, and they're reddening of skin, hair loss, ulceration, and skin erythema typically starts at a dose of 2. And if you look at this publication, there was only about 1% of patients that received a skin dose exceeding 1 milligray. So really deterministic doses, even with CT-guided interventional procedures, are really not of concern. But stochastic risks, which is the risk of carcinogenesis, assuming the LNT model, which remains controversial, is something we still need to worry about. And actually, I would like to dovetail into Dr. Rahani's talk, in which he mentioned like some myth busters about, okay, you know, these patients in whom we're doing biopsy for tumors all have malignancy. So why bother with doses? And I say I have 2 good reasons. One is, I just say is just good practice. That's why you bother with doses. Number 2 is that's where for me, most of my learning with CT radiation doses actually came from procedures. It taught me, you know, what is my sensitivity for low dose, like how low can I go? I learned that from interventional procedures, and I applied that subsequently to diagnostic procedures. So it was a good learning, and that's where you develop good habits on trying to be dose cognizant. So factors when interventional procedures that contribute to high dose is there's repetitive radiation of a limited anatomic territory, because you have to do multiple scans when you're doing procedures as you're placing instruments and needles. Protocols are loosely defined. A lot of interventional radiologists, and I hate to say it, are actually are purely interventional and don't have a deep understanding of the concepts of CT. And they just let the technologists, and this is true at my institution, they let the technologists run the scanners, and the technologists will just kind of pick a protocol, and it'll all be like based on like, oh, you know, can you give me a better image? There's discomfort with noisy images. Often technologists will use default diagnostic imaging scanner settings to do interventional procedures. There's obviously variability in technical skills in needle placement. So the longer time you take to place the needle, the more the images, the more the dose. there's also a perception that you may not just see the lesion at a low dose, which is actually, again, a myth, not true. There's ways to deal with that. And then occasionally there are patient factors, like if the patient's inconsistently breathing, I mean, that will result in more scans, and there are things you can do to mitigate that, and I'll talk about that. Finally, I would like to emphasize very, very key aspect is communication between team members, and I find this to be a very major factor in doses, because oftentimes, the radiologists and the technologists are not communicating effectively in terms of a plan to keep the doses low. And when there's good communication, you can reduce radiation doses. I want to show some examples of in practice. This is these scans are from a few years back when I started over here at UC Davis in 2004. So these scans are dated 05, 06. And often I would get these images, and I would notice that simple procedures, like in this instance, drainage of a psoas abscess, where a drain is being placed, and the psoas abscess is actually visible quite clearly. It's a retroperitoneal fluid collection in this case. And if you look at the localizing scan, the guidance scan while the needle is being placed, and the completion scan, they're all done at reasonably diagnostic doses, which are not necessary. So the MAS over here, the KV was kept fixed at 120, the MAS was 255. You can see the CTDI wall was not adjusted, or the dose was not adjusted throughout the acquisition. And this patient had an effective dose of 10 millisieverts. Not terrible, but not needed. This procedure can be done, in my opinion, with a dose of about 2 millisievert, probably lower. Similar sort of instance in the lung, and again, very unnecessary. MAS is set at 336 for the localizing scan, for the guidance scan. No adjustment has been made. The entire procedure has proceeded without making any adjustments to the radiation dose, and all acquisitions have been acquired helically. And we'll talk about why that's also not a good idea, resulting in a total dose of 15.7 millisieverts and a total DLP of 1043 over here. So that gets me to, it was interesting when Dr. Rouhani mentioned a question about convenience. And I would say that convenience is a very, very big factor in our lives. I mean, if you look at what's happening with global warming, if you look at what's happening with what I call is use and abuse of plastic or a single-use water bottle. I mean, many of us, including myself at times, will grab a single-use plastic bottle to drink water from, rather than fill my stainless steel thermos, with some water, just because it's convenient as you're walking out of the house. So convenience drives a lot of stuff, and a lot of radiologists find doing a procedure with CT to be more convenient rather than doing a procedure with ultrasound. In my practice, I do about 95% of all my interventional procedures with ultrasound. I cringe when I see someone doing a liver biopsy with CT, even if the lesion's in the hepatic dome. This is a whole separate talk that I could give for an hour about the use of ultrasound for interventional guided procedures. But I do all my liver biopsies with ultrasound. I do 99% of my renal biopsies with ultrasound. I do pelvic masses and event occasionally with an endovaginal biopsy. I place pelvic drains, endovaginal or endorectal ultrasound guidance. All superficial mass biopsy, lymph node, thyroids, superficial collections are all done with ultrasound guidance. All liver abscess, cholecystostomy, superficial fluid collections, patients with difficult breath holds. I'm going to show you some examples of what are traditionally procedures that are done traditionally with CT that we do with ultrasound as well. So adrenal biopsy, retroperitoneal biopsy, deep pelvic node biopsy. I mean, lung biopsy is an exception, although subpleural masses of the lung, I do those with ultrasound as well. Peripancreatic fluid collections can be difficult. Those are often done with CT. Like I mentioned, deep pelvic abscesses, most people will do them with CT. I do them with endorectal or endovaginal ultrasound. Obviously, for obese patients, sometimes you have no choice, but you have to use CT. There are some simple examples. A lesion segment 7, pretty far behind. A lot of people will look at this and say, that's a lot of depth, portal veins in front of it, or we're just going to use CT. We're not going to see this lesion in ultrasound. It's a pretty straightforward target. If for someone who knows how to use ultrasound and is adept at it, and oftentimes it's one straight shot, and we get the biopsy. So it's just an example of one. And we do far more difficult locations than this. Segment 4A high dome, segment 8 high dome. We do all of those with ultrasound. Renal biopsy, again, almost 99% done with ultrasound. Adrenal biopsy, left adrenal. You can do it. The typical ways to do it: lesion side down. Lung can occasionally get in the way, especially, right-sided. Especially if it's right-sided, I often use ultrasound and go transhepatic. Small adrenal nodule over here, highlighted by the red arrows, transhepatic approach, straight in. And we've now done about, when we're collecting our data, about 11 right-sided adrenal biopsies with ultrasound. So I want to go with the structure of a CT-guided interventional procedure. First is the localization and planning scan, where you've got to localize the target and then plan your path. The second is a set of guidance and monitoring scans, in which you're obtaining multiple sequential scans as you advance your instruments into the lesion, and you confirm that your instruments or the needle tip is in the lesion. And finally, a post-procedure scan, which is typically done to check for any post-procedure complications. But in my opinion, if you don't have any bleeding by the time you're completing the biopsy, I will often skip the post-procedure scan. There's opportunities to reduce the MA as you go along. You can start off at sort of what I would say a comfortable dose, and if that dose is adequate and meets your needs, you can keep dropping the dose, and I'll show you examples of that. Carly, are you going to keep track of time? I mean, I did not set my timer. I totally forgot.
Yes, so we're running about 10 minutes behind, so I think we'll start lunch around 12:10, unless you finish up sooner, but you've got about 15 minutes more.
I got 15 more. Okay, thanks.
Including Q&A.
Okay, just give me a 5-minute heads up, please.
I will.
Okay, then I'll pace myself accordingly. Yeah, I was giving a talk once, at SAR, and the computer systems went down. So we lost some time, and I was with Doug Katz. I don't know if some of you may know Doug Katz, and he proudly said, we'll make it up. I'm from New York. I can talk fast. And so he did his thing. He talked fast, and then I was following him because it was a 2-person talk. And I said, I'm not from New York, but I can talk faster than him. So deep pelvic fluid collection aspiration. We started off the initial scan at 100 MA. This is a deep pelvic collection. The patient was having high fever, so it was suspected that this was infected. This is post-colonic resection reanastomosis. So we got the first scan 180 MAS. I saw the collection. I made my plan. I knew where we needed to go. We dropped the MA to 36, the MMAS to 36. We placed our needle. Everything's looking good. Needle shows up well. For the next scan, I dropped a little bit more, 24. Now, I do know as I'm going to advance the needle, there's going to be an artifact from the needle tip in CT. That's that black little artifact that you often see. Most of us are familiar with that. So I knew that all I need to see is that black artifact. And my needle's on trajectory, so I don't need a lot of dose, even though 24 mass is a very low dose. But my whole point is, it's just like everything else. We're just in the habit of like, oh, it doesn't hurt anything. Why do I care? Let me keep prescribing whatever dose I need. I mean, why bother? No, yes, bother. So we dropped it down to 9 mass. Because all we had to do now was get into the collection. We were on track. All I need to see was an artifact. In fact, when you drop the dose, the artifact from the tip shows better. That's a little secret. So it's actually beneficial to drop the dose. And then a post scan to just make sure that we aspirate everything. We got about 12 cc's of pus out of this, was obtained at 6 mass. So, and that's all you need. There's no need to crank up doses. As you can see, sequentially, we're dropping the dose. It's called a sequential lowering of dose technique that I don't have a patent on, but it's pretty much common sense. And total DLP here was we were able to get away with 430. And most of the dose is coming from the initial scan, the 357 of that 430 actually comes from that initial scan. And by the way, that's where communication comes in. That initial scan was obtained by the technologist before the radiologist arrived. So that's where I personally forbid them from getting any scans till I'm there. And a lot of times you get grief, like, oh, it's going to delay things, the patient's on the table, and, because I'm running between multiple rooms, but they're strictly forbidden from acquiring scans till I get there. Dose reduction, target localization and planning scan. So this is that initial planning scan that I talked about. The biggest opportunity is to limit the length. All opportunities in radiation dose optimization are in prevention. That's where the bulk of the opportunities lie. It's not all retroactive, let's get like a 2,000 centimeter territory coverage and we'll drop the dose. No, let's get what we need. So limit the craniocaudal scan length to relevant anatomy. Use the widest collimation, which reduces overbeaming. That's a physics concept that I'll talk about. I kind of love overbeaming, and its corresponding thing that I'll show you in a second. And then obviously sequentially reduce the MAS. Let's look at some examples. Limit craniocaudal scan length. This is a 60-year-old, has transitional cell carcinoma of the bladder. There's a left retroperitoneal lymph node at L3. This is the original scan that I'm showing, by the way. But then we did a planning scan, and for the planning scan, we stayed generous. We knew where the node was based on the anatomic bony landmarks. So we told the technologist, just scan between mid L1 and mid L4. Oftentimes, if you don't have that communication, they might actually scan the entire abdomen pelvis. That does not happen infrequently. I've seen that happen as well. So we just need a limited coverage. We could have even gone shorter than that, but for the initial scan, I think it's okay to be a little generous. The scan length over here was 6.3 cm. We didn't need the entire anatomy over here. And then the other thing I wanted to talk about was the use of the axial mode versus the helical mode. That I'll talk about in a second, but I'm going to talk about using the widest collimation. So why use a wider collimation? So there's something called overbeaming in CT. A little bit of radiation dose falls beyond the CT detectors. It's called a beam penumbra. This is unnecessary dose. It does not contribute to the image. And if you use a narrow collimation, just watch this. You increase your penumbra. Again, let's do this again. You're increasing your penumbra. So you need wide collimation whenever possible. So if using helical mode, which is your first scan, use wide collimation. And we'll talk about not using helical mode for your guidance scans. And then reduce the MAS sequentially. So in this patient, the diagnostic CT, the original CT, was done at 320 MAS, which was the diagnostic scan. And then we did the localizing scan. We knew where the lymph node was. There was calcifications in the aorta, so we knew the node would be right next to that. And we'd observed that on the initial scan. So I just got the initial localizing scan at 90 MAS. And that's all you need. And that actually is a 72.5% lower dose for the initial scan compared to the diagnostic CT. Here's an interesting example of one of my colleagues who got the first planning scan at a reduced dose. They probably had attended one of my talks, or I've actually written a couple of papers on this as well. So they did this, and then they looked at it and said, I'm not comfortable with this. It's very noisy. The arm's giving an artifact. So went ahead and bumped the dose. I think that's where some of the problem lies. Some radiologists perceive images as noisy and they feel that they need to see things better, when in fact you're seeing them fine. So in this case, they actually ended up bumping up the dose. So I thought this was interesting. And I had a chat later and said, I was not comfortable with the image. I didn't know where the abscess was. Oh, well. Okay. When you get these guidance and monitoring scans, we talked about the importance of breath holding, accurate needle placement, and then I will introduce the concept of using intermittent mode CT fluoroscopy or the axial mode. If you do not have intermittent mode CT fluoroscopy, which I absolutely love, and that's a great way to do interventional procedures, then just use the axial mode. And there's opportunities to reduce the MA further, like I showed before. So if you have consistent breath holds and accurate needle placement, your number of guiding scans will decrease. In this patient, I wanted to show highlight the importance of multiple highlight the downside of multiple guidance scans. This is a difficult location. It's a mesenteric lymph node. It was FDG avid, and they're trying to get the needle into it. I mean, frankly, I would do this with ultrasound. I would push the bowel out of the way and just place the needle with ultrasound. We'll have CT available to us. We typically do procedures with ultrasound in the CT suite, and then we would check the needle like intermittently just to make sure everything was going okay. Anyway, so they're trying to place the needle, difficult location. There's breathing in wall, patients breathing, and here's the dose report. 11 sequential scans obtained to place this needle. So how do you achieve consistent breath holds? One thing is you sedate the patient before the initial scans. You don't want to get a scan when they're breathing normally, and you place the grid and then you mark the spot and then you sedate them. Now they're breathing differently. So I sedate them before obtaining the scan. And I try to keep them very sedated. If they are in fact following breath holds, I prefer expiratory breath holds, which are more consistent than inspiratory breath holds. But typically what I try to get them to is a level of sedation where they're just breathing gently. And I typically slap oxygen on them, 4 to 6 liters face masks or nasal prongs, so that they're comfortable and they're not hyperventilating. If the patient's going to be not sedated deeply, then we do practice coaching. We coach them on breathing consistency, and that's time well spent and very useful. Accurate needle placement is simple. It's an interventional technique that most radiologists should be good at. But essentially, your XY placement, if you use the laser light, you can get the needle down in one shot, as long as you use the laser light. So there's no need to do multiple placements. You can get it down in one shot. Intermittent mode CT fluoroscopy, great tool. Typically, I use a 5 millimeter or one, depending on the lesion, or a 1 cm collimation, 5 millimeter 1 cm collimation. It gives you 3 images, and this is with the GE scanner. We have 2 monitors in the room, one on the right, one on the left. So we can be on either side of the patient and we can observe what's going on. Is single, soft, one touch on the pedal. You never keep it held down. And I'll just show you some examples. Here's the pelvic fluid collection.
Dr. Lamba, this is your requested 5-minute.
Oh, okay. Well, we'll speed it up. We're getting there.
Okay.
So left pelvic fluid collection, you can see, the collection is pretty well seen. These are guidance and monitoring scans done at pretty low doses over here. Now, here's a retroperitoneal lymph node biopsy, the same patient that I showed you earlier, who had the TCC with the metastatic paraaortic node. It's an 8 millimeter node. It's a small node, but we see it, and we don't need a lot of radiation. And this is being done with intermittent fluoroscopy. And these are the images. And if you look over here, smart view and the GE is when fluoroscopy is going to be used. If you look at the exposure time, it's 0.02 seconds. That's the amount of fluoroscopy that was used. Total DLP for the exam, 71.53, 59 of which comes from the initial localizing scan. And by the way, positive result. If you don't have intermittent mode fluoroscopy, then use the axial mode. There's a phenomenon called, I talked about overbeaming. There's a phenomenon called overranging, in which, there's again radiation at the start and end of the helical range, which doesn't contribute to images. And that's a fallacy of helical. So anyway, if you look over here, highlighted in red, we're using axial mode. This is with the GE scanner. We're using the centered mode. All we're getting is 6 images. So you can get a small number of images in the axial node without turning on the helical mode if you don't have intermittent mode fluoroscopy. And there's always opportunities. To keep reducing the MA as you're advancing the needle, because if your needle's in the right trajectory, then you know where you're going, and all you need to see is the artifact from the tip if you need to localize the tip. So again, 150, 160 sequential lowering of the dose. I think we're good. Post-procedure scan. In this case, I placed a chest tube. All I wanted to see.
Hello everyone. I'm Lina Karut, postdoctoral research fellow at the Webster Center.
Post-procedure scan, all we wanted to do with the post-procedure scan was see if the pneuma was resolved. And we got it at lowest kV setting of the scanner, 80 kV, and a mass of 6. CTDI wall was 0.11 for the post-procedure scan. Finally, last tip if you can keep your CT dose low, and if you want to improve your image visibility or your lesion visibility, you can give contrast. How is contrast given? The needle is first placed to the best of your ability, to the best of your guesstimate. And then after you place the needle, then contrast is injected to confirm if the needle is in the right spot. In this case, as you can see, the needle was a little eccentric, and then we just adjusted it. After we gave the contrast, we used only 40 cc's of contrast over here, enough to just light up the tissues around this pancreatic cancer. And interestingly, as you can see, we went through a transcaval approach. Now, this is a kind of patient you actually cannot do with ultrasound. With all the skill in the world, you have to do this with CT. So this is how we use contrast over here. Some suggested, and I think the slides will be sent out, or you're welcome to share them if you guys want, if any of the folks want them. But essentially, I do most of my scans now at 140 kV. And why 140? Because you get better tissue contrast, but I keep the MA low. And I typically measure the patient. So if it's less than 30, so four sort of measurements we do at the iliac crest, and these are the suggested MAS settings. At 140 kVp. And our current scanner does not have iterative reconstruction, so these numbers could be more aggressive if we had iterative reconstruction. But our current scanner is pretty old, and interventional scanner does not use iterative reconstruction. So 5 takeaway points: use ultrasound when feasible. I mean, it's a great skill to have. Use lower MAS for all scans compared to the diagnostic scan. So it's very easy. You look at the diagnostic scan and you can just say, okay, you know what? I can do my procedure with half the dose. That's a starting point, and then you can keep lowering after that. Intermittent mode CT fluoroscopy, and if you don't have that axial mode or more dose efficient, restrict your craniocaudal scan length only to the relevant area that you need to work on. And then obviously refinement of technical skills for needle placement will result in a decrease in the number of guidance scans. And all of these techniques put together will result in reduced dose CT procedures. And this is where you will, once you start doing this, you will learn a lot about your tolerance for low doses. Thank you.